to our second in our webinar session on AVT. I'm Breed O'Brien and I'm delighted to be chairing this second session. I'm an independent consultant, started my career as a nurse, and have worked in many clinical, operational improvement and technology roles. And as I said, I've had the joy, and it was a joy, of chairing the first webinar, and really excited at the level of engagement we've had since then, with lots of people, lots of dialogue, and over 200 people expressed an interest in joining our special interest group, which you'll hear a little bit more about later. I am going to be at risk of repeating myself here, so because I know there's new people that haven't joined the first webinar. But as I said before, for me, AI is seen as the solution to many of the NHS woes by many people. And I'm personally really interested in how AVT can help both improve care delivery and the work lives of our staff. But like most people probably here, I have a healthy degree of caution about how we do this right. And today's focus is on the really important topic of quality and safety, because that was something people said they'd like to hear more about from the first webinar. But it's a really big topic, so today will be the start of a conversation. So do use the chat to connect with people, because it's through connections and sharing that we all learn. I've no doubt you'll hear from our speakers that quality and safety is not just relevant when looking to go live. It's also going to be really important that it's front and centre as this progresses. It needs to be continuously attended to as we work with these products and ensure they evolve in a safe way. And getting this right will also help the tech to evolve and work with our partners in a way that it's a collective effort to make this work for everybody safely. I'm cautious, of course, but it's equally important that whilst it's really important we deal with the quality and safety challenges, it's equally important that we don't let perfection stop us doing anything. So today is also learning from some of the, I would say, test and iterate approaches that people have used. So again, my encouragement to everyone on the call to ensure you're centred to the conversation about how AVT supports clinical care, because one of our original reasons for doing this is to ensure we raise the voice of nurses and therapists and others in what to date has been a reasonably medically driven conversation. Not saying that's a bad thing. Well done to our medical colleagues for taking it this far, but we need to make sure it's an MDT voice. So whether you're joining today as a novice, and I know we'll come back to who's in the room in a moment, a real enthusiast, a nurse currently using it, or a supplier, I hope you're going to get lots from today's conversation. And we recognised in the first one that this is not just about tech and productivity. It's about improved human interactions. I personally have had some healthcare experience since the last webinar, and I have to say what was a really empathic interaction with the clinician, the keyboard and the computer really got in the way. So I'm particularly personally excited about how we can use this to make care more patient-centered. So, housekeeping. Webinar will be recorded with note-taking. We will share everything. So please, there is no need to bring your own note-taker bot, because we had some issues the last time with everybody getting emails, somebody's notes and things. So please, if you're trying to bring in your note-taker, don't. To focus on speakers, delegate cameras and microphones will be switched off. If you have a question for the panel or the room, please ensure you use the QA function, because that's what we will use to both pick up the questions for the panel and to respond to any of the ones we don't get to. But do use the chat to connect with other attendees, share contacts, comment on things. So there's two things for you to think about. And to our supplier colleagues who've joined, a warm welcome. This isn't sponsored by any supplier, so please, no product placement or sales in the chat, because we want this to be really about how we all learn together. Who's in the room? So it's interesting that we have 25% of people have come back for more, so that's great. And we know some people couldn't make today, so that's a good reason for that. But a special welcome to the 32% who aren't members of the Future Nurse AVT SIG. So please, there's a QR code there if you want to join the SIG, and it'll come back later. Please do so. Again, a good section of people who are some understanding of the previous work, currently learning, and minimal. So welcome, whatever your level of expertise is. And again, across all the levels of nursing, we've got a good broad representation. And I love the fact that people are saying they'd be interested in sharing safety cases and processes. So we need to maybe tip that a little bit as more and more people develop theirs to say, how can we share more? Do introduce yourself in the chat so that way people can connect with you. So I think that's probably enough about me. I'm going to pass over straight away to Helen. Welcome, Helen. Helen is our National CNIO at NHS England. In fact, we've got Natasha, who was previously, we've got Helen, who's now, we've got, these amazing women leading the voice of digital nursing. So Helen, over to you.
Thank you. And we might have the next CNI of the country in the room as well. You never know.
Absolutely. And so it doesn't have to be a woman,
future.
Sorry.
Absolutely. So I'm going to talk to you about unlocking the power of AVT. So there is a lot of work going on nationally. I'm going to give you some insight into that and talk about some of the professional issues that are emerging. So let's crack on. Next slide, please. This is a typical doctor's view, isn't it, really? And I wanted to start with this because I think we're coming a long way since this was the case. In many cases, most of us are dealing with electronic patient records, but we do know one of the key challenges has been having to understand a keyboard at pace. So there's something about when you're in front of a person, you haven't necessarily got the secretarial skills to use that keyboard well, and you want to be able to focus on the person. So this technology really does enable us to use our voice potentially for some really good conversations and almost forget that skill of the keyboard. Next slide, please. But ambient voice technology, there's lots of different things in this space. It's generative AI. It is moving us forward. So it's one of those big things that people are going to have that could, and I'm also a cynic breed, it could enable quite a lot if done well. And it is about using our voice to do a number of different things around consultations and those interactions we have in the with people. The evidence behind it is predominant with our medical colleagues, but it is about one-to-one consultations, regardless of where those might be, although most of them are in a consultation room in a building, not necessarily in somebody's home. The biggest study in the world is very much the one that was led by Shankar from Argosh. And that started testing this technology in lots of different places on scale. So 17,000 patient encounters is massive, and showed the benefit in places we may not have initially thought of, because we're moving beyond where is this technology growing, because it is developing. But the consultation room, absolutely. Emergency departments, which is, some of the busiest areas that we see, because we know we've got huge challenges in there. But you can see from the data there, those studies showed a potential for a massive impact. They also tested it in community clinics. So we saw AHPs and nurses use it in community as well as primary care colleagues. So lots of different experiences, and overall suggesting this is a technology that could really help us deliver safe and effective care. Next slide, please. It does fit with all of where we're trying to go. Clearly, many of you will be aware there's lots of changes across the NHS at the moment, but a lot of where we're trying to get to is digital by default, where it's appropriate to do so, and it's not in all cases, we know that, but digital as that enabler of high quality care. Ambient voice technology fits a lot of those core elements, and that's called out in this slide, but I'm not going to linger here. So next slide, please. The impact, and I think that's the bit that really interests me, is what could the impact be? Because that actually goes, what's the strategic driver? Why might there be a national programme? Should we not just let teams carry on where it has a benefit? And I think what we're starting to see is we know we need to change the NHS. It's not necessarily financially viable to keep going in the way that we're going, but we need technology to help us reimagine how we might work differently. And this technology in particular is showing that we might be able to move more people through a one-on-one consultation, but at the same time deliver a better experience, support more effective content in our record. And that experience piece for those using the technologies was those on the receiving end of care. So there's a great potential here, but it's only about as well as it's done and delivered in practice. Next slide, please. This is a slide that's work in progress, so take it with a pinch of salt. And I've put it in here because this is a maverick place. There is lots of different AVT types of solutions, and some of it's about what's the problem you're trying to solve and what's the right tech solution for you, because they all do slightly the same things, really. A lot of the existing AVD capability lies predominantly in that basic transcription and note creation. And that's all well and good, but actually some of the next points are going, you said you wanted to prescribe this. Here's your prescription. You said you wanted to make a referral. Here's the referral. Do you want to send? And it's about nudging us, making it easy to do the right thing. And what we're seeing in primary care in particular is coding is so important. They're going, and we need the technology to code. So lots of different things looking at lots of different places. And the coding is an interesting one because some of the international studies suggest that our humans are still better than the technology. So I think we're going to see lots of changes in this space as this technology starts to evolve. And that's happening at pace and across the world. Talking to some colleagues, like just last week, they were going, everybody's asking about EVT. It doesn't matter whether you're in Europe, Australia, New Zealand, America, everybody's going, this seems to be that next big thing that's taking the world by storm, but it's not one thing to one place. Next slide, please. So when we start looking at it from a national lens, and it's not the only lens, many of you will have got more experience of AVT in practice than I have, but looking at that progress to date, we've put out some guidance, and we'd say it caused a little sensation at the time, but version 2 is in development, and that's coming with some IG guidance in particular, because that's what you've all asked for. There is some standards that are being created as part of that modelling. And of course, you've seen the registry. Now, the registry is just a point in time. It will evolve and grow over time, and the longevity and how that's going to be managed, clearly as this technology evolves, is being discussed at the moment. But the next phase is very much about how do you mobilise this at scale so that across the NHS we get the benefits in this space. And it really drives us forward, whole system. It's almost like, I'm comparing it to when we rolled out EPRs, but trying to go faster so that we've actually got this in the places of care that it will really make a difference of. And where is that? What are the areas, under discussion? And the answer is everywhere. And that's interesting because we don't have a strong evidence base in this space. We're coming back to the research that's been published, but actually we know with a lot of the case studies, a lot of them have been written about our medical colleagues and how they found it. Yet I know myself, having run a nurse-led clinic 20 years ago, and indeed had some clinical pathways that the only thing the surgeon did was the surgery. All people that are running a one-on-one consultation need access to that, regardless of what profession they may be from, because this is the technology that could really help us deliver great care, regardless of setting. But the ED piece keeps coming through. What about the patient's home? And they are all things we need to build the evidence case from it. We shouldn't wait. Don't wait for national. Absolutely. If you've got the technology, test it, use it. I think it'll be interesting when it gets to inpatients. The studies at the moment are predominantly in America, and of course very different setup in the fact that they don't have bays, they're all side rooms, so it's still one-on-one. But what's going to be coming through when it's a bay? What are the different issues? So some tests of change we still need to evaluate and go, what are the things that we need to understand and learn together? Next slide, please. And I'm going to go to the next slide because I think I've talked to that one, but it is in your pack because I'm being told I'm running out of time. So the issues that we're really seeing is actually take time to do the implementation and adoption really well. It's no good having a handful of people using it. You want to do it on scale, have that safety culture, have that learning culture, because in all AI, one of the things that's absolutely critical is that post-market surveillance. So you do need to make sure you've got it in and you're learning as you go through. Professional responsibilities and liability is coming through. How much do you trust the tech? You are still putting a note into a legal record, so you do need to read it and sign it before you actually enter it. So some really interesting things. And I've put there about function, not profession, because like many, I'm hearing it's all about our medical colleagues, and it's not. It's about everybody that delivers care. So use your voice. But the one thing we can start preparing people is to start addressing the issue of silent care. It would appear as nurses, on the whole, we're really good at doing a task, writing it down, but not necessarily saying it out loud. And our American colleagues that are testing it with one supplier are going, silent care is a thing, but in AVT that won't work. You have to talk out loud. But the feedback from the public and patients on that is fabulous. They're going, we feel better informed about our care. So use your voice. But I would ask everybody to build the evidence case. Share your stories about what you're using it for, what worked, what hasn't. Think about those benefits in productivity, the workforce elements, the quality of care, especially the experience for those of you using it and your patients, so that we can really all learn to go together and smarter, faster, building on what we know. I am going to stop there and pass over to the next one. Thank you.
Thanks, Helen. And sorry, I feel bad because
No,
we
it's
could
good.
speak for hours on this, couldn't we? I'm going to go straight over to Rachel. Please do pop questions in the chat, in the Q&A, sorry, for Helen. We will come back to questions at the end. We're going to do rapid fire with the 3 presentations. So now we have Rachel Brown. Rachel is the Deputy CNIO and Head of Nursing at Manchester University NHS FT. So Rachel, over to you.
Good afternoon, everyone. Okay, so I'm going to go through Manchester's approach to AVT. And we've taken a digital fundamental service transformation approach, and we've embedded AVT within our wider digital strategy and vision. So AVT isn't a standalone project, it's part of a broader programme of digital transformation. And I just wanted to know its value. So I briefly wanted to focus on the why. And one of the biggest challenges for nurses, midwifery, AHPs is documentation burden. And the figures on the slide highlight the significant time spent on admin tasks. And this impacts patient care, staff wellbeing, and it's a real barrier as well to service transformation. Our staff are feeling fatigued. So the core value for AVT is to streamline that documentation and enable clinicians to spend more time, caring for patients, time to think. But being mindful that technology alone won't solve workforce pressures, and that success depends on a system-wide readiness, leadership, culture, data, quality and infrastructure and governance. And that's why we've taken that programmatic fundamentals first approach. So focusing on digital capability, on training, on system readiness to ensure we can realise the intended benefits and return on investment. Next slide, please. So following on from the why and using this model, I just wanted to capture some of the key elements that have helped sort of us as an organisation and myself in a clinical safety role with AVT to safely deploy it effectively. And this is where the AVT readiness framework comes in. And though this has been put together with the thought of AVT in mind, it's equally applicable to wider digital transformation, and it may evolve over time. There may be further domains to consider, but it gives a good starting point. And I wanted to give some sort of local context as well behind this. So at Manchester, we use Hive, which is powered by Epic, and that's our EPR, and that gives us a real solid digital foundation. However, when we initially piloted AVT, we've used Microsoft, and therefore that's a challenge with 2 systems, and we needed to consider integration. The first sort of pilot required a copy and paste workflow. And as you can imagine, from a clinical safety perspective, that presents a potentially high scoring hazard. And from a usability perspective, it's quite clunky. And in all honesty, we did lose some users at that stage. However, the second phase moved to more full integration, and this was much better received, but it required that strong vision, effective digital leadership, working alongside our analysts through the data and the AI infrastructure, and we had to consider that. And then from this month, we're now piloting both Microsoft and Epic AVT solutions, so it's reflecting that increased digital maturity in that journey. So with that context, I wanted to introduce the 6 dimensions for safe, scalable AVT. This framework sets out core elements needed to deploy AVT safely and effectively from both a clinical safety and an operational perspective. Bearing in mind, we know that digital initiatives often fail when the basics aren't in place. So frontline staff can feel unprepared, safety risks increase when training doesn't reflect the right workflow. And also that strong digital foundation is essential. For us, the EPR must remain the single source of truth, and therefore AVT must integrate seamlessly into existing systems. So creating those bolt-on systems can duplicate work and undermine both efficiency and safety. So we've taken these factors into account. It, for us, highlighted the need for a holistic maturity framework rather than a purely tech-first approach. Next slide, please. So what I want to do over the next 2 slides is just look at those domains in a little bit more detail. And those are the ones that I've illustrated on the model on the prior slide. And it really did help me when I looked at the AVT clinical safety aspects, and moving AVT from pilots to safe scalable options. So the first dimension to look at is vision and system leadership. AVT must clearly link to trust strategy and workforce priorities and not sit as a standalone element, and that's what good looks like, because if that vision is weak, we can potentially see disconnected pilots and inconsistent uptake. The second domain, user-centered design and value. So as mentioned, AVT must solve real frontline problems, particularly documentation burden. If we don't articulate that value, clinicians don't see the time saved, or there's not the friction removed, adoption simply won't happen and we won't get that engagement. The third is digital foundations. So AVT, particularly at Manchester, must be embedded into the EPR and not bolted on. We've noted where copy and paste required. If this domain is weak, that we can lose efficiency gains and we can increase our hazards and safety risks. So these 3 dimensions ensure AVT is strategically aligned, genuinely useful and technically safe. Next slide, please. So AVT success would depend on data quality, workforce readiness and strong governance, which leads us to the 4th dimension, which is data and AI infrastructure. So AVT only adds value if the inputs are high quality. So structured data into EPR and strong integration. So it's getting your foundations right, your workflows right, etc. Poor data quality or weak integration, will result in poor uptake, safety issues, and the long-term value we won't be able to articulate. So the 5th dimension is workforce skills and culture. So AVT adoption relies on that digital literacy. So it's again that foundations, users being able to use it, give it wraparound support around training, feeling that they can trust the systems. Without this, we'll see resistance low and adoption errors. And finally, governance, ethics and benefits realisation. So this ensures AVT is safe, transparent and delivering measurable value. And it's not just innovation for innovation's sake. So without governance and risk, we potentially could breach compliance. It'd be variation in practice and an unproven scale up. So these 3 dimensions ensure AVT is safe, trusted, and able to demonstrate a return on investment. Next slide, please. So final slide, and to close, there's some takeaways and considerations. So this framework helped support what good practice looks like for deploying AVT safely and at scale, and there's some considerations in there. But as we, move forward with, more research into AVT, there may be further considerations. But I wanted to recognise that that digital maturity, infrastructure and workforce readiness do vary across organisation. I think, Breed, you touched on it, aiming for perfect straight away can be challenging. We've quite digitally mature organisation here at MFT, but there's not a one size fits all starting point. But what matters is not having necessarily everything perfect, but having clear principles guiding adoption. And these principles are that shared vision, user-centred design, strong training in workforce, robust clinical information governance and benefits oversight, and real key strong engagement around your fundamentals, your architecture and data elements. And where these fundamentals in place, AVT can be introduced safely, which is the main element, scaled responsibly and deliver real value. So at MFT, we've taken this fundamentals first programmatic approach, and that's helped us balance innovation with safety and ensures that we can support our clinicians, and they're at the centre, not the other way around. So AVT, I suppose a closing line would be AVT succeeds not because of the technology itself, but because of the systems around it are ready, and you've got that clear engagement with your users. Thank you.
Thanks, Rachel. Really useful insights and real world, real life experience. I think that's the huge value here. Before I go to Charlotte, just to remind people, the Q&A, there's lots of questions coming in. So please do vote for the ones you want answered first, because we want to make sure we cover as much as possible. But straight away over to Charlotte. Charlotte, delighted to have you, Lead Digital Clinical Safety Officer at Hampshire and Isle of Wight NHS FT. And I have to say, my attention came to Charlotte because she and her colleague did a fabulous podcast, which maybe we can share as well for people who want to hear more. Charlotte, over to you.
Thank you. Next slide, please. So, I work for Hampshire Isle of Wight Healthcare. We are quite far into this pilot now. It started off, the initial conversation was from our CAMS team wanting to look for a solution for their large assessments. We had sort of an AI workshop, and it came very clear that we needed to broaden the pilot and to use a wide range of clinicians in a wide range of settings. So we did do that, 25 teams. That includes sort of our asthma nurses in the community, our urgent care response teams in the community, CAMS assessments, physios, you name it. We had a professional piloting it just so we could get a real wealth of information about where it's most useful or perhaps where it's not. So we issued initially 145 licenses. There were 30 role types, and we piloted 4 suppliers. That gave us this huge amount of information, and we were able to do lots of evaluation on it. So we looked at usage data, time and motion studies, patient surveys, staff surveys, focus groups. We did over 20 hours of patient interviews. I did several rounds of hazard workshops because what we anticipated before might be hazards and risks, actually when we then started to pilot the products was quite different, so that was really useful. We carried out a large clinical audit that was incredibly time consuming, and I do think one of the challenges we're going to have with AVT and AI products is that post go live monitoring. It's not to do that audit, we had to compare the verbatim transcript to the summary that the AVT generated to then what the clinician put in the notes. So as you can imagine, if you've got a 2-hour ADHD assessment, that took a long time, but it was a really valuable exercise and we learned a lot from that. Next slide, please. So consent, very early on, this was a bit of a knotty subject. So there is a requirement to record that you've obtained the patient consent when using the AVT tool. Quite naturally, most of our clinicians asked that before pressing the record button. When we carried out the audit, none of that was captured. So it did look as though we were not obtaining that consent when in fact we were. So that was a key learning point that we had to share with the clinicians and make sure that was embedded into our SOPs. Obtaining consent. Obtaining consent with some patient groups reacted negatively to that. So getting your phrasing right, and also remembering that AVT isn't for every single patient. It will not be appropriate. So using your clinical judgment in those situations. And we did have some report back that consent question was straining rapport between clinician and patient. Next slide, please. We did come across hallucinations when we carried out the clinical audit, capturing incorrect information or pinning that information on the wrong person. So if you had multiple voices in the room, if you're in somebody's home and you had 3 children, dog, granny there, it was sometimes put the script to the wrong person. And as I said, that was really difficult to independently audit. So just reiterating the importance of your final accuracy check to the clinicians before committing that to the record, and sort of saying to clinicians, this is a great first draft, but it is just that, it's a first draft. It will always require you to check that. And that's quite a big change in practice. Medication details of what medication is something that the tools do struggle with. I'm pharmacy by background, so I was obviously really hot on that when carrying out my audit. And where the products are keen to please, they want to give you the next bit of information. So it was quite difficult when you're carrying out an accuracy check to actually notice that, because it wasn't, we had some funny hallucinations like patient ordered elephant pizza. Okay, that's obviously that wasn't what was said. But when we had situations where a patient would say, I use a purple inhaler, the tool would capture it as patient uses Seretide 125 microgram inhaler, 2 puffs twice a day. That was never said, but that's actually the most plausible dose. So picking that up was really important, and sharing that learning. Next slide, please. So once we've gathered all that information, we put some mitigations in place to make using the tool safer. We didn't have any real robust governance around it, so we developed an AVT organisation-wide SOP. We did that in consultation with our participants and also with our colleagues in the mental capacity assessment team. We are currently developing tailored in-house training, which is going to be in the format of an e-learning module. So anybody that's issued a licence will receive that. Supporting clinicians in this change in practice is key. I've been hosting, still on, fortnightly reflective practice sessions, which I've had really good feedback from. So one of the things that's important is to configure your template to be able to use it best in your settings. So in those sessions, clinicians will share templates, they'll share how they approach certain subjects, or how they make sure they capture their consultation effectively with each other. So I think, this is such a leap forward in technology, and we need to support our clinicians through that change. And also to bring along those that might be a little bit more hesitant to use this technology, having those sessions have been really useful. We've had to update our clinical record keeping policy, because obviously that didn't include the use of AI tools. And we have an overarching AI use trust policy. Next slide, please. Some other considerations, initially the templates were able to be modified to include non-approved features like diagnosis. So we've had to ensure that's disabled in the tools. Some specialities have had to sort of adapt, because you, as I think Helen touched on earlier, you're now speaking out loud your cues. Particularly physios that have reported that it can affect patient behaviour if they're manipulating a foot and they say, oh, patient appears comfortable, and then patient says, no, I'm not, I'm in a lot of pain. So it's how do you rephrase that to make sure that it's not affecting your consultation. And in some settings, we found that external microphones have improved the performance of the tools. Next slide, please. We had fantastic feedback from our staff. Everybody that participated in the pilot did not carry out any overtime. They finished during their normal working hours, which, as we all know, is really unheard of. The documentation quality was high. There were no major omissions, and 85% of clinicians were satisfied with the tool. Next slide, please. There's some lovely quotes here from our patients, but generally they were really happy because they felt like their clinician was more engaged. You've taken that barrier away of the keyboard. They felt listened to, clinicians able to maintain eye contact. One learning point that we did take was from the patient interviews was patients over 80, they were happy to use the tool, but they didn't feel that they quite understand exactly what it was. So on the back of that, we've developed leaflets, which are all in our, in our waiting rooms, and then that gives them an opportunity to have a read and discuss, consider it before they're then asked the question. And no concerns were raised at all about the clinicians introducing the technology. Next slide, please. That's it from me.
Wonderful. Thanks, Charlotte. So I was going to go to the panel for reflections on each other, but we have got lots of questions. So I think I might just go to the questions if that's okay with you. But please, it would be interesting when you're answering, Helen, if you've heard anything from a national perspective that's made you think, oh gosh, we might need to do more of this because we could do it once. Or equally, Rachel and Charlotte, if you've heard anything from Charlotte or from each other, do feel free to bring that into your responses. The most upvoted question is Rachel Binks on consent. But Charlotte, if I could ask you to read that first whilst I go to another question, because I think you've covered quite a bit of it, but perhaps you could pick up any gaps. Helen, I'm afraid I'm going to come to you first. You've got a couple of questions, a couple of sticky ones here. We've got a question from Jerry. I don't know if you managed to see it, about clinical safety. Huge variability in both the quality and depth of the supplier's documentation, and that the register isn't necessarily assisting this. So a bit about how is NHSE going to help with the scenario of solutions being used outside of their intended use, whilst manufacturers are basically using the register as a way to get this uptake more. And then there's a similar question from Sarah around, as AVT is considered a medical device, will the AVT registry meet MHRA requirements, and what systems are trusts going to use to record software as a medical device? Really complicated, because this is an evolving situation. So maybe just give a view, but I think something maybe to take away is a bigger.
Yeah, I will take it back to the team that are leading on this. I think, the registry, when it's set up, yes, it did include the MRHA, and certainly they've been partners as we try and move some of these conversations forward. Also looking with Department of Health colleagues of what's the future of the register, because it's, as I said, it's only a moment in time, and this technology's changing, evolving, developing. So, it's got lots still to learn. And we know, though, it is changing some of the behaviours of suppliers. And we know that because they're coming and telling us that they're ready to be assessed to be on the register, or no, this is what their plans are. So it is interesting listening to the different dynamics, but I think it comes down to what technology what's the problem you're trying to solve in your organization, and what's the best fit for that, and what do you know about all of the different software options that are on the table. But I think, as Charlotte beautifully puts, it's not just about the software, it's about the hardware. You need the good microphones, so it needs to be embedded into ways people are working. So this is relatively new and emerging to do it this way, but lots more to learn as we keep going down this direction. Hope that answers the question.
Thanks, Helen. And I'll come back to you because there's another one for you about the independent sector from Linda Jones, if you want to have a look. Rachel, can I ask you any advice? I love Ingrid's question. Any advice for Band 5 nurses looking to be involved in AVT integration? Because I feel the nursing voice needs to be really strong. So what would your advice be? And well done, Ingrid, for asking that question.
Yeah, no, good question. So what we've tried to do at Manchester is put expressions of interest out, and that is at the moment we're only doing outpatient spaces in terms of consultation with a patient. So that's where we're focused on, but the future roadmap is to look at inpatient workforces. So I suppose it's understanding what's going on in your organisation, and having those conversations with the digital team and seeing where your roadmap is with AVT and how you can get involved. We're quite keen on putting those expressions of interest out and having motivated users come to us and say, we want to trial it here, and then we've looked at that workflow, but we're going at the pace that the technology will allow and at the pace that we're at. So at the moment it's outpatient areas, but very, very soon we are, within the next month, we'll be looking at inpatient, and that will be open to, ward staff supporting patients. That's going to open up a whole new world of possibilities and risks and things that we need to look at. But my advice, if in your organisation now, reach out to your digital team, your digital colleagues. What's going on in the organisation? How can you get involved? You want to be a champion? Can you spend some time with them? You know, it's just about having an interest and seeing where you can have a voice in that.
Great, thank you. 'Cause sometimes it's hard to get that voice, isn't it? So really good. Charlotte, I'm going to come back. So I thought maybe you had answered some of Rachel's question, but she says not quite. So would you like to respond to the consent question? And obviously, Rachel, if you feel you want to come in on that as well from your experience.
Yeah, so Rachel, there is a separate requirement to ask that consent, and we are required to do that. That was advice from NHS England, so it is different to viewing the EPR. We do need to explain that we're using an AI-powered tool as ambient voice technology. If the patient didn't have capacity, you'd use your normal principles. So if it's, you know, a child, are they GILA competent, or are they, you know, do they have their power of attorney there with them? It'd just be the same things that would apply to any sort of capacity conversation. Does that help?
Breach, you're
Yeah.
on mute.
Yeah, thanks, Charlotte. I think that's answered the question, but Rachel Binks, please pop in the chat if there's a specific bit that you feel isn't answered.
Will do.
Sorry, Rachel Binks. Sorry, the person who asked the question. I realise there's two Rachels. And Helen, can I come back to you on the question about the independent sector?
Yeah, absolutely. And I have to be honest, I'm not the best person to ask, but I will go away and find out. Certainly from the e-learning perspective, there is e-learning available on the Learning for Health Hub. That's where that is the several modules to complete. There is in-person CSO training, and there is a raft of different providers that can deliver that. That's not just NHS delivered. So I think it is exploring with different suppliers who delivers that training. I don't know some names are not coming, my menopause brain not coming to mind off the top of my head. But
Charlotte and Rachel, you might have a view on this as well. I went to Helen first because it was addressed to her, but Charlotte, you're a CSO, so do you have any advice on that?
Of what? Sorry, what
on
was
this
the
question? So this is from, as a member organisation for the independent sector covering England and the devolved nations, where can members access the required training for independent sector staff in digital clinical safety, please?
Yes, sorry. Yeah, so as Helen said, there's the online e-learning for health, and then there's Safe Hands as a consultancy company that you can go through privately and self-fund.
And I think some of Safe Hands colleagues may even be on the call. So
and there are several. And there's a national procurement framework for education providers as well.
And Jerry has just put in the chat, I love this. This is crowdsourcing responses. Jerry's just put in the chat, DPM Healthcare also do training. So yeah, keep sharing any of your intel for each other. That's great. So there's a question in here. I'm sorry, I'm trying to keep up with the questions here now. There was a question about languages from Wales because of Welsh. Where is it? I'm just keen that we pick from around the country.
Does it translate, doesn't it?
Would AVT be appropriate for use when the consultation was undertaken in a language other than English from Wales? So some people may feel more comfortable speaking Welsh. It's relevant to any language, isn't it? So I don't know who'd like to take that one.
I'm happy to take that one. So our tools were able to translate, but because we weren't able to audit that and get assurance that it was correct, we've decided not to use the translation function for now. So our speech and language teams are really keen to turn that on, but we have disabled it for now because we just can't be sure that it's accurate, because you haven't got that final accuracy check and, you know, the human in the loop that we have when it's in English.
And certainly it is worth talking to your supplier, because there are some suppliers that say, yes, they cover some different languages, but they're very specific which, and there are others that go, no, we don't cover anything other than English. So this is very supplier specific. So it comes down to what's the problem you're trying to solve, what's all of your asks, and what are your criteria when you make your choice of which solution is the best one for you.
Yeah. Really helpful. Rachel, coming to you, a question from Claire, saying thank you for sharing your framework. So we popped it in the chat as planned. Could you share some example services of successful implementations at MFT? So maybe actually to you and Charlotte, just what services, anything additional you want to share on that?
Yeah, so at the moment, I'm doing a bit of a service evaluation on the NMAP users, because it was originally for NMAP, sorry, there's me with my acronyms, nursing, midwifery and AHP users. So what it started out at was a medical kind of pilot, and I was supporting clinical safety on it, but that was due to the very nice, clean consultation spaces, shut the door, doctor, outpatients, that's where it started. And we weren't having that, were we? So it was like, no, let's explore this with other colleagues that we have. So we have physiotherapists using it. We have nurses, IBD nurses. We've gone out into lots of different disciplines that are with NMAP. And what we're trying to do now is understand how that works for them. And one example that really made me think is I went to a cardiac rehab clinic, and there was an absolutely fabulous physiotherapist, and she wanted to pilot AVT, but what she had was a laptop, and then she had a phone, which was the device that we would use for the AVT. So she was using the phone because that had all the application on. And then she was also getting up to take blood pressure and put a remote monitoring, but wasn't integrated into the system. And then as part of those pathways, those patients had to have those blood pressure checked at different points. And this lady was walking, and I was just like, oh no, this is not right. We're giving her this innovation, but we're not thinking about end to end. So what was the end user device that would have made it better for that patient? Could we have looked at a tablet where the microphone was included and she could have gone on the EPR and updated? And could we look at a remote monitoring device? Now that's the art of the possible, but we appreciate finances, etc. But it's just made me think that when we are looking at rolling this out with our NMAP users, because we work in such varied spaces, we just need to take that second to think, are we getting it right? Are we making it more difficult? So that is a piece that I'm really interested in at the moment.
And Charlotte, really, really useful insights. It's the environment as well as the product, as well as the personal interaction, isn't it? Charlotte, anything you wanted to add to that?
No, just to echo what Rachel said. Yeah, it's getting the device right for the right clinician.
And Rachel, I think it was you that said to me you had this vision of, someone doing dressings on bilateral leg ulcers, and that actually at the moment what people do is they write little bits of measurements on gloves. We don't really do that, but and then you write it all down at the end. But actually, if you were doing it and you were talking out loud as you're doing it, you would say what the measurement was. The patient would hear, it would be much better. And then at the end, you would just take your gloves off and throw them in the bin and not think, oh my gosh, I've thrown them away, and suddenly the measurements are on there. It just felt like a really good example of how we could get to a different opportunity.
Yeah, I always felt like I needed another pair of hands when I was there. You've been there, you're trying to get your clean space on a little bit of paper from a pack, and you're trying to do this person's dressings and talk to them and remember your measurements, and it's a lot, isn't it? And then we've got to write it up and order some dressings, etc. So that's my ambition there, is to see district nurses out there using it and safely in patients' homes.
I mean, the patients will just know so much more about what's going on, won't they? That comes back to Helen's point of nursing out loud.
Yeah.
So there's a question in here for all of you, actually, from I'm probably going to pronounce the name wrong, so sorry, I can't see it properly. Who do you believe should be driving the shift to AVT, clinicians, clinical team, or digital colleagues? It's actually a really good question, because I'm sure it varies everywhere.
I think with any sort of health IT systems, the drive should come from the clinicians. And certainly in our trust, now that the word of the pilot has spread, there is a huge demand. Everybody wants it, and we can't quite accommodate that at the moment. But yeah, I think definitely it should come from clinicians, and then we can support and guide as digital colleagues. I think that's where CSO is such a great role, because you are that bridge between the clinical and technical teams.
Yeah. Rachel, Helen, anything you want to add? Any thoughts?
I definitely user-centered design, but I'm really fortunate to work with some amazing digital colleagues, analysts, and a lot of them have been clinicians as well and moved into more analyst space. But you need that stakeholder engagement, because, as I always say, I'm not technical, but it needs to be user-centered, because we're doing it for our users to make their work lives easier. So it has to be with them in mind.
I agree. Digital transformation takes a team, and it takes a multidisciplinary team, and that includes our digital colleagues, doesn't it? And I've said that for years. but different times we need different elements of that team. And I think we've got to balance what's achievable, what's the right solutions for the problems we're trying to solve, what do we need to have in place, what can we afford. But also, I love both of you've talked about, and that improvement approach. And I'm very firmly of the view that if we're doing something that's going to change the way in which our people work, then that's the approach that we need to use, so that we really do capture actually what are we doing, why are we doing it, how do we learn, and then scale with the evidence base behind us. Because it's not the same in every clinical setting, in every clinic, because we're all human, we do it differently. But I love the approach that you've both described, because that's what we're trying to do, because that's what makes it sustainable.
We haven't talked much about the patient, have we? And we've got a couple of questions. One from Joseph Woods: are there concerns that a negative cultural shift may affect larger patient groups who then decline consult when using AVT and potentially other AI technologies? And if you look at some of the negative press around OpenAI and Anthropic last week from the US and things, people may become a little bit more concerned. So that's one. And then I think I just saw one coming in, another patient one. Let me just see. Or maybe it was just a comment in the chat. But yeah, how do we make sure patients that, we bring them with us and that they feel, involved, consulted, helping, coming back to your user-centered design? I mean, my patient experience, I'm an even bigger convert than perhaps I was previously. But yeah, views on patients.
I think I read recently a piece that was done by the Ada Lovelace Institute on patients' views on AI, and it's worth reading. They've done it a couple of times. Ooh. And there's some really interesting stuff in there about the public's perception of AI generally, not necessarily AVT, but AI generally. And I would encourage people to have a read, because people are very up for AI that can make a better diagnosis. And I think there's something about, we're going to see some real, as we see new technologies coming in, it's going to change some of what we do, and some of it will add value and some of it won't. But it is about, how do we build trust while we're still learning? And I think, there is a lot of hope for AI, and some of it will be realistic and some of it not. But there is something about, actually, we want to have a conversation with you, and we'd rather do that in a way that helps us look you in the eye, actually be able to see where you're pointing to, not me looking at a screen. So I think there's something about, how do we tell the population or encourage them to have those conversations openly and transparently. And I have written it down that we probably need to create some information that everybody can use if we're really going to scale this well. I think, Charlotte, you mentioned that, and I think it's a really good thing, because I think it's about the consequences of not having this technology in the room, because we know satisfaction isn't as good when nobody's looking at you, they're looking at the screen all the time. And if we're really going to develop person-centered care, then we need to look at the person holistically, and this technology offers that potential. Whether it's achievable is how well it's embedded in some of the work that Charlotte and Rachel have discussed.
And maybe we can get that link from you that we could send out when we send out the recording and stuff, or pop it on the Future Nurse site. Charlotte, Rachel, anything you want to add on the patient perspective? That might bring us to the closing, because got a couple of things.
When Helen said trust, I think that's really important. How you introduce that to the patient, assure them that their data is not going to be sent anywhere that they wouldn't want it to be, and that it's not stored, and that this is going to improve your experience and your consultation. And then if you introduce that, you've built that trust. But you can see from our patient interviews, once they'd had it, they saw the benefit. But it's about that first bit of that conversation, I think.
Yeah. Rachel, anything from you?
Yeah, just to mention, we do a quality impact assessment as part of, reviewing any new technology or any project. And we offer consent, making sure that they're aware of it. So it's that informed consent. We've done a leaflet. But if they don't want it, that is okay. And actually, sometimes with digital transformation and innovation, it's going to help a cohort of users and they're going to be engaged. But if that's not the case, there is more space for those people that want, because we're freeing up time if more people want to use AVT, and then we've still got a cohort that don't and want to, have, a face-to-face and not have any AI, that is okay. But we've got more space for that because we're increasing efficiency using other tools. And I still always say, like, it's not going to suit everyone. With a mother with macula, when everyone's gone to digital letters and things like that, she can't use that on her phone. So what works for her? So it's just understanding that you cannot have a one size fits all. And as long as you've considered that, then there's other opportunities to care for patients.
Brilliant. That's a nice way to finish our panel Q&A. It's really about the users, whether that's patient or staff. The tech is an enabler, and I think that human-centered piece is really important. I'm now going to invite Linda and Natasha to come off mute, and if we can put the slides back up, Jules, just to speak about the special interest group, because 200 people want to know more about it, where we've got to. Things have been moving at pace, but it takes time. And then Natasha will speak about a specific next step. So Linda, to you first, quickly.
Yeah, thanks, Breed, and thanks all the panelists. You've been absolutely great. So I'm Linda Havard, and I am co-chair of the Future Nurse AVT SIG with Hayley Grafton, who is CNIO at University Hospitals Leicester. We set the AVT SIG group up. We listened to the community. We put a survey out, and there was a really strong desire, as these webinars have shown, that people actually want to get involved. We know there's some people who are involved and have got that experience, but we wanted to bring it and make so we could enable that nurse and nursing voice to be at the table with our other clinical colleagues. So it's about all of us, indeed. So we've had over 200 people that have expressed an interest. We've identified a small number of people to be part of the AVT SIG advisory group, and that's going to help us sort of drive how we support you and to get that information out. So it's a community-led group with some expert learning opportunities. As I've said, we've got this sort of community leadership involved. There'll be webinars like this one, workshops, opportunities to network and to have discussions. So we're just trying to work out what the platform's going to be. So we're going to be very soon setting up the advisory group, sort of chat and meetings, and then we'll be able to, spread that message wider. So if you'd like to be involved, and there's quite a bit in the chat of people that I think want to be involved because they want to learn more. We've got some really experienced people there who are already doing it, who want to share that. So please head over to Future Nurse, fill in the little bit of paper and say that you want to be involved in the AVT SIG, and then we will be sort of contacting all our interested parties in the coming weeks to tell you how you can be involved more. So it's just great to be in this space. Really, really important for our nursing, midwife and AHP colleagues. Thanks, Breed.
Great, thanks Linda, and thanks for all the work in getting this far. Natasha, next slide. Oh, you're on mute.
Indeed. Thank you, everyone. Thanks, Linda and Hayley, for stepping up to chair that group. Thanks for all the interest, and thanks to all our speakers today. So yes, as Linda suggests, really keen. There's some great stuff in the chat with people of experience who'd like to share. We'll be definitely taking you up on those offers. But do go over, as Linda said, and join Future Nurse and put on your contact form that you're particularly interested in SIG, but there's lots more happening other than AVT SIG, and you may find there's other areas that are of interest to you. One of the key things that we'll be doing to take this conversation forward is an event on the 29th of April, Nursing Out Loud event, which will be held in London. Now, apologies, this will be for a smaller group, but remember, Future Nurse is a think and do tank. So this is very much about the think tank element and trying to make sure that we capture the richness of the knowledge in this room, in this community, and bring a smaller group together to have a detailed conversation in order to produce a white paper that really clearly articulates some feedback and recommendations to influence national policy, and leads like the wonderful Helen, who's joined us today. Thank you, Helen, to take forward how we adapt this for the practice of nurses, midwives and AHPs. So moving beyond those clinical settings that are very much in the one-to-one consultation space and beyond, but thinking about some of those broader issues. So we will do that in partnership with our academic partners, University of Salford. I was really struck, we met this week, and they have started a literature review. They will also be analysing these webinars, which are available in a public space, as you've all consented to. So they'll be analysing our conversation and bringing the thoughts of this group together into the room with that literature review. But the literature review was striking 12 out of 344 studies of AVT were related to nursing practice. So that tells me that we need to do much more in terms of knowledge sharing, and that might be through their empirical studies type work, but it's also more broadly through stuff like this. So just to let you know that that will happen. You will have the chance to have your say through both the analysis of the conversations we've had so far, through a survey that will go out that will inform the discussion in the room, and ultimately we will share that white paper with members, but much more broadly working with national bodies and our professional bodies to make sure that we're speaking with one voice to influence policy and make sure that this truly delivers on the benefits that it promises. I think that's all I need to say about that, and I've probably gone over. We're over by 1 minute, Breed.
We're
Apologies.
over by 1 minute. I wanted to say thank you to everybody. A huge thank you to a very engaging panel. Thanks for giving your time, both in the prep of slides